In Karlsruhe, talking about patient-specific models of atrial fibrillation.
Oh, yes, I can. Yes, thank you for the introduction and to all the organizers for the invitation to this really stimulating meeting. So my talk is titled Towards Patient-Specific Simulation of Atrial Fibrillation. So that's a really broad field and many people are working in this personalization. And I just want to give you like 3 spotlights on issues that we are dealing with and possible solutions that we have. So first of all, I will present an adaptation of a minimal model to reproducing atrial excitation properties. Then I will talk about torsioconductivities and how they influence the forward calculated surface ECGs. And finally, I will talk about the simulation of intracardiac ECGs as they are measured in clinical routine. So let us start with the cardiac simulations. So on one hand, we have detailed ionic cell models used in the bidomain or monodomain framework. And they're very detailed, but also time-consuming. And on the other hand, there's very simple systems, cellular automata, which are rule-based but suffer from discretization effects. So the question is if maybe there's some intermediate solution. And here, Bueno Orovio and Elizabeth Jerry and Flavio Fenton, they have proposed a minimal model last year, which basically describes 3 major currents. You may think of them as sodium, calcium, and potassium. And it's only controlled by 4 state variables. And now you can tune this model with a set of 28 parameters, like time constants and threshold voltages, to reproduce the action potential shape and also restitution properties as you desire. And now they supplied parameter sets for the ventricles, as you can see here, but none for the atria. And therefore, we adapt the parameters such that this model reproduces atrial excitation properties as described by the complex Courtemanche model. So we did this in 3 steps. We started by adapting the action potential shape at a frequency of 1 Hertz. Then next, we took a selected set of just 6 parameters, which more or less control the APD restitution curve, like the threshold and the steepness of this restitution. And then finally, by just adjusting 3 parameters, you can tune the, let's call it sodium reactivation, so also the steepness and the threshold. And once this is done, you can see the results. You can see the minimum model in red and the reference Courtemanche model in blue at different basic cycle lengths at like 1000 milliseconds, 500 and 300. And you see how the shape more or less matches. And also, if you have a look at the APD restitution here and the CV restitution, you can see that the properties more or less match. Now, on one hand, it's interesting to have a minimal model due to computation time. But on the other hand, also, when you think about personalized model, you know, you have a patient coming into the clinic and you have really scarce measurement data probably. So now if you want to adjust the model because this patient, he suffers from some disease, so you cannot just use the normal physiological setup, you have to adjust it. And so here you have just a small defined set of parameters which you can tune these restitution properties with. And therefore we also think that this is interesting for patient-specific models. Now next, I will have a very quick look on torsioconductivities. So we are simulating this cardiac excitation in the atria, as you can see here, or in the ventricles. This is the visible man heart. And now we want to do a forward calculation to get the ECG on the body surface. So we have to create a model of the torso, putting in all these organs, the lungs, the liver, you all know this. And we're doing a forward calculation to get the ECG. But of course, these tissue conductivity values, they're very important for the results of the forward calculation. And we have to know how do the changes in conductivity affect the ECG. And are there maybe some organs that we do not have to include at all in our models? But unfortunately, it seems, although there are several studies on this, there's not really consistent data. So there's not this one truth that we all are looking for. So we also started analyzing this in the visible man geometry. So this is some preliminary results here, but we tried an analysis where we changed the conductivities of different organs by plus minus 25%, extracted the 64 channel ECG, and then compared the signals at these different conductivity values for one organ and analyzed it quantitatively with different measures, like, for example, the root mean square error, which is also very sensitive to just scaling of the signals. And also like the correlation coefficient, as you can see on the right side, which is rather sensitive just to changes in morphology of the signal. And then you can see there's organs here. This is for the atrial signals, so for the P wave, which are more important, although the order is not the same, but here like the skeletal muscle, blood, lungs, fat tissue, they are more important, also here this block, than the other organs. And as I already said, we also heard this in the talks before, we have to know about the errors that our simulations actually introduce. So here we know like for which organs we should get more exact conductivity values, if it's possible at all. Of course, it also varies sorry, from patient to patient. Or at least like do some analysis like if we change the conductivity by so many percent, how much is the error, so how good is the like a confidence interval or whatever for these signals. So in the third part, I would just talk about the simulation of intracardiac ECGs. Because when we think of patient-specific models, then it's really two questions, like how can we adapt our model to the patient? And once we have adapted the model, how do we validate it at all? We cannot just take a model and say it's patient-specific, but we have to do some validation. And also convince the medical doctors that actually our models are kind of true. And so, when we think about atrial fibrillation and pulmonary vein ablation, there's a lot of data available in the clinic where intracardiac ECGs are measured by such catheters. So patient coming to the cath lab is introduced catheters through the veins into the heart, you know this. And there are different types of catheters, like in the coronary sinus, a stationary catheter is placed. Maybe it's hard to recognize. There's these electrode pairs, and you will have this catheter there as a reference signal. And then there are these circular mapping catheters. They can actually be moved around in the atrium, so measuring different spots, measuring the potentials, and then decide, for example, where to do the ablation. And now our idea is that there's so much data available that this could be an interesting interface between our models and the clinical data. So we have to somehow simulate this data, which means we need the extracellular potentials from the model and extract them at the correct position corresponding to the catheter shape. So when you think about these circular mapping catheters, we created a tool where you can adjust the radius of the catheter, the number of electrodes, maybe some overlap, and you will get a catheter in your model. this is the right atrium through the tricuspid valve here. And then first we did just some simulation studies with these signals, but also did a first comparison to patient data, which we got from the hospital in Karlsruhe. So it was from a 60-year-old female patient, and she suffered from atrial fibrillation, went there for pulmonary vein isolation. And now from the clinic, we got the ECGs, and also from the NAVIC system, this mapping data. And here in red, you can see the catheter. The black dots are the electrodes, so you see it's overlapping. And now we just took the visible man atrium and created a similar catheter here, close to the left atrial appendage, which you can see here in the mapping data. So it's not exactly the same position. We just manually had to place it in that region because it's also a very structured region in the model. And apart from that, we didn't do any further model adjustments either, so no tuning to make it look better or something. We just looked at the simulated and the measured data. So you can see the simulated data in the left column here, and the measured data in the right column. And you can see there is some qualitative similarities, like some of the waves are looking similar, and also this activation pattern where you can see that this region is activated earlier than this region is similar. But of course, there are also many differences in other signals. But I mean, there's so many uncertainty factors here. Like we were using a different simulation geometry, and the catheter position was set manually. And also this area in the model is very structured. It's difficult to get the potentials out there. Neither did we include any anisotropy or like conduction pathways, the Bachmann bundle or crista terminalis. And from the patient side, it was a patient suffering from AF, so there may have been pathological changes. Also, the clinical data is filtered. But what I want to show you here actually is that this may be a starting point for the further model adaptation. So now we can start tuning the model parameters to make these patterns match even better. And as I said, it's so interesting because there's so much data available from the clinicians, and it's really used in like everyday clinical practice. And this is the data that the clinicians are actually familiar with. So you don't have to tell them use any new method, new device. It's just like you meet them where they are actually in the data they know. So I'd like to thank all the co-workers at the Institute. Martin Krüger is also working on personalized models. He's got a poster here on anatomical modeling, and Osama Jarous. Then the project was funded by Philips Research, and the clinical data, as I mentioned, are from the town hospital in Karlsruhe. And finally, I'd like to thank you for your attention.
Okay, then time for perhaps one quick question.
Hi Frank. Do you think that the use of contact mapping system will help it better comparing to the non-contact mapping?
Yeah, I think in the, you mean this activation imaging with a non-contact mapping system. Yeah, I think, you know, the interesting thing about the contact mapping is that it's really done on the surface, so there's no interpolation done. And with the non-contact mapping system, I think you can get a general overview of the activation times. There's also much interpolation. And I don't know actually if it's used so much in the atria. I don't know, it's, I think, rather used in the ventricles, or maybe Cavallo. I think this non-contact mapping is rather used in the ventricles, right?
Can be used.
Atria as well.
Yeah, okay. Okay.
I mean, it's much more error prone, the non-contact mapping system. But,
it does give you beat-to-beat data on a lot more points.
Yeah,
an
yeah.
advantage.
Yeah.